Good afternoon. My name is John Belzer, and I am the chairman of the Department of Orthopedic Surgery at California Pacific Medical Center, and I am a member of a private practice group called the California Pacific Orthopedics and Sports Medicine. I've also been the team physician for the Golden State Warriors in the past. I want to thank you for joining us today for our talk on the anterior cruciate ligament. We are going to speak about injury, diagnosis, and management. I want to let you know how the program is going to go today. First, we're going to have a presentation by myself, which is going to include about a half an hour of discussion points on the anterior cruciate ligament, and this will be followed by a question and answer period where I will answer questions that many of you have submitted, and I want to thank you in advance for doing so. So as a brief overview today, we are going to speak in our outline here about these topics. So we'll start off with prevalence of ACL injuries, followed by the anatomy of your knee. Then we'll talk about the biomechanical role of your ACL, or why your ACL is important to knee function. We'll speak about injury in terms of the mechanisms of injury and the types of activities that tend to create these injuries, the diagnosis made by your physician, the treatment of these ACL injuries, and the outcomes of these treatments. Finally, we'll speak about special considerations as well as the prevention of ACL injuries. So the prevalence of ACL injuries is there's about 100,000 to 150,000 ACL injuries estimated to occur in the United States every year. There's also an estimated surgical reconstructions of 75,000, potentially higher every year at a cost of $1 billion per year to the healthcare industry. ACLs occur in about 1 out of every 3,500 people in the general population, and football tends to again represent the #1 sport in terms of the incidence of ACL injuries. However, the rate of injury is much higher in women's gymnastics. What a rate means is the number of injuries that occur per participation hour. So an episode is a practice or a sporting activity. Women's gymnastics has a rate of injury of 1 ACL injury per 3,000 episodes, meaning it's practice or sporting activity. So it's a very high rate. And we see this across the board in many ACL or many sports in terms of ACL injuries. Women have a rate as high as 8-to-1 over men in sports such as gymnastics, basketball, and soccer. So I know many of you know the anatomy of your knee, but I'll briefly review this. There are 4 bones. These are the femur, or the thigh bone, the tibia, or the main leg bone, the fibula, which is the smaller leg bone, and the patella. These 4 bones are joined together by the 4 main ligaments. The anterior cruciate ligament, the topic of today, is labeled there on the photograph on the right. You see it's in what we call the notch, or the central portion of the knee in between the 2 runners, or the condyles of the femur. There is a ligament that crosses behind it. We call this the posterior cruciate ligament. Cruciate means to cross, so these 2 ligaments cross over one another. The collateral ligaments, the medial collateral ligament being on the inside or the medial side of the knee, the lateral collateral or on the outside of the knee, prevents the knee from buckling inward or outwards. There are 2 types of cartilage in the knee that are important in terms of knee function and structure, and these cartilages can get injured in an ACL deficient knee. These cartilages are the meniscus cartilage, which fills the gap between the otherwise incongruent femur and tibia bones. You see this is a cross-section of a true knee joint, and the black triangle fits between the 2 white segments of the joint. That black triangle is the gasket, or the meniscus cartilage, that sits there to act as a shock absorber to the knee. The ACL protects this structure. The white structures are the articular cartilage, both on the femur and the tibia. This is what all joints have, the meniscus being somewhat more unique to the knee joint. And finally, we'll talk about muscles and tendons. The quadriceps muscle is the muscle that extends the knee. It joins to the patella, and then below that is the patellar tendon. So when you pull on the quadriceps, that's what pulls your knee into a straight position or extended position. The patellar tendon is one of the choices that we will use for what we call autograft, or reconstruction of your ACL with tissues from your own knee. The hamstring tendons represent the flexor tendons of the knee, those that bend the knee. And you see those labeled on the right-hand side of the photograph on the right. Those tendons will oftentimes also be used for reconstruction of ACLs. Now, what is the biomechanical role of your ACL? Well, the ACL stabilizes the tibia-femur articulation. I have a model here I'm going to try and show you. I hope you can all see this. This is a right knee. Here's the fibula that you see here on the right-hand side, the femur and the tibia. Inside the knee joint, you can see the ACL deep inside the knee. Now, the idea is that as you flex your knee, the knee joint bends like this. The femur, I'm not sure if you can see this well, but the end of the femur is round down here at the bottom. As you flex that knee, the knee has two choices. One is to essentially roll backwards. The other is to actually spin on top of the tibia. Ideally, we want the femur to stay on top of the tibia, so as we squat down, there is still contact between those two bones. The ACL's job is to stabilize that. So the ACL traverses from the back of the knee here, as you can see both on this model and on these images you see on the slide. And it traverses to the front part here on the tibia. That angled translation is what supports the knee and holds that tibia back underneath the femur. So in this slide we show, again, what I was just demonstrating, that your ACL maintains the femur over the tibia throughout a range of motion, keeping the keeping the femur properly aligned over the top of the tibia throughout a range of motion. That is important not only so that you bear weight, but also so that there's congruity between the femur here and the meniscus, which is that wedge-shaped structure you see in this orangey rust color here. So in terms of this support where the tibia is maintained underneath the femur, 90% of that restraint to the forward translation of the tibia is provided by the ACL. So when the ACL is lost, the tibia tends to slide forward, as you see demonstrated here on this model. I'm going to try and get that centered on that picture there for you. So you can see that the tibia will slide forward when the ACL is lost. Now, it takes about 1,725 newtons of force to tear an anterior cruciate ligament. Now, it's not important that you understand newtons of force. I have trouble understanding it myself. But the forces to an intact ACL, as a relative term, we can look at other activities. So, for instance, passive knee extension creates only about 100 newtons of force to the knee. That's if you were to take your knee and just straighten it out. When you walk, that only creates about 400 newtons of force, and that's why we don't see ACL injuries with day-to-day activities. However, when you start participating in cutting or acceleration-deceleration type sports like basketball or soccer, the stress to the ACL approaches approximately 1,700 newtons of force. And when you start to get up to that level, the threshold for injury is very close, and this is why we see injuries in these types of activities. So what are risk factors for ACL injuries? Well, these are the four main risk factors: hormonal, anatomical, environmental, and biomechanical. So hormonal, it has been proposed that the reason that there is a significantly higher rate of injuries to the ACL in female athletes is that there is an increase, with the increase of estrogens in patients, this softens the ligament and may result in an increased risk of injury to the ACL. Anatomical risk, we talked a little bit earlier about where the ACL traverses through the notch of the knee. If that notch is very narrow, that is an anatomical consideration or an anatomical reason that the ACL may be torn. If that notch becomes exceedingly narrow, there's very little room for that ACL to move. In terms of environmental, the biggest environmental cause is the foot contact to the ground. For instance, in sporting activities such as basketball or soccer, you're looking for performance to have a very tight or very sticky type of interaction between those two surfaces so that the athlete can perform at a high level, being able to make hard cuts on those surfaces. If you start to slip on a basketball court or your feet can't grip on a soccer field, it's of not much benefit. The problem is that the stickier those surfaces become, the higher risk that you have to having knee injury. But other injuries can occur if your feet slip out from underneath you, so it's kind of a slippery slope there, so to speak. In terms of biomechanical considerations, these include Poor training. If a patient is not in good shape, the weekend warrior may be at a higher risk for developing ACL tears for many reasons, and we'll talk about that in a little bit. So injury mechanisms. The most common injury mechanisms, interestingly, are non-contact injuries. These are simple deceleration type injuries which can occur with jumping or slowing down from a fast run in a forward direction. Other types of non-contact injury include cutting type activities that you see on the image on the right, where this basketball player is making a hard cut to go from his left to his right. And then contact injuries represent only about 30% of these injuries, and it occurs generally when there is a blow to the side of the knee that a football player may experience while in a football lineup. When that blow occurs to the side of the knee, they may suffer not only an anterior cruciate ligament tear, but also medial collateral ligament tear, as well as potentially meniscus damage because of the type of torsional injury that occurs. Again, injury activities, number one is football. You can see that valgus or outside blow that I was just speaking about on the football photograph on the top right. But basketball, soccer, and downhill skiing also have significant numbers of ACL injuries occur every year. So how is the diagnosis made? Well, diagnosis is made by three arms. One is clinical history, one is physical examination, and one is imaging. In terms of clinical diagnosis, the classic patient history is given in terms of the patient telling the physician that they had a sporting injury in one of the activities usually that we mentioned before. The patient will oftentimes feel a pop or a shift in the knee. And when they try to stand on the knee after that initial injury, the knee will feel unsteady or unstable, or sometimes it just doesn't feel right. It doesn't feel connected. There may be rapid swelling because there is an artery within that ligament, and when that ligament ruptures, that may actually pour a lot of blood into the knee joint, and that rapid swelling can occur over the course of 20 to 30 minutes, and you may see swelling as demonstrated on that photograph on the right side on that patient's left knee. So the diagnosis is made by a thorough examination by your physician on your knee, which includes inspecting the knee for swelling, inspecting it for abrasions, or other abnormalities. But the classic findings that we talk about when we talk about anterior cruciate ligament deficient or anterior cruciate ligament injured knees are the anterior drawer, the Lockman's test, and the pivot shift. So the anterior drawer is when the physician bends the patient's knee to about 90 degrees and will simply pull the tibia forward to see if it translates underneath the femur. An abnormal amount of translation when compared to the other knee is the suggestion that the ACL is torn. Oftentimes when patients have a large amount of swelling, we're unable to flex the knee to 90 degrees, and so we do the Lockman's test. That's done with the knee a little bit more straight at about 20 degrees of bend, so just a gentle bend. This test is much easier to do for the patient simply when they're on the sporting field. Physicians can get a very good idea immediately of whether the knee is injured. Now, a pivot shift test is a more complex test that looks at rotation of the knee joint, not just the simple translation forward. That rotational test is, in my opinion, the most important test of the three, because that is the test that looks at the level of true instability the patient may exhibit. So when a patient has rotational instability, that's when their knee feels like a trick knee that your grandfather may have talked about. Instrumented laxity testing is just an objective way of measuring the amount of translation. It's a machine that puts a pad on the kneecap and a pad on the tibia, and by pulling on the tibia, you can measure the actual degree or millimeters of translation of that tibia. It is used in clinical studies, not commonly used in a clinical practice. So I'm going to show you basically the one test that I like, which is called the pivot shift test. You see in this image, I'm in the operating room. This is a patient's right leg. You see my hand is just about the level of the knee. And when I do this test, you'll see that I'm going to slowly just rotate the knee and show that the knee is unstable. I'll start off very lightly, just simply bending and straightening the knee. This is of no harm to the patient in the operating room. And as I push just a little bit harder, again, not placing much force at all, you'll see that the knee will shift a little bit. And this is what gives the patient a sense of instability when they are participating in sports, when they have an anterior cruciate ligament deficiency. So you can see the tibia slides forward, and it just makes this little shift. As you watch as I do that, you can see much more dramatically how that tibia slides back and forth. So when that happens, that is during participation in sports when patients instantly feel like their knee is giving out on them. they might experience that the moment that they stand up after a skiing accident, their knee will shift, and that's the sense of instability that creates problems for patients. Now, in terms of imaging is very useful, though X-rays not very much so. MRIs are extremely important for ACL diagnosis. So if you look at the images on the right, the one on the left shows, again, as I mentioned before, the ACL that's intact, where it traverses from the back of the femur on the upper part to the front part of the tibia. So the left side of that image is the front of the knee. The right side of the image is the back of the knee. On the right image, you'll see that the ACL is no longer attaching to the back of the femur. It has simply been torn off the back of the femur, is laying down on top of the tibia, and thus has resulted in this image looking abnormal. The other reason MRIs are very important is that they will tell us about additional injuries, injuries to the medial collateral ligament, for instance, or the meniscus cartilage, or the articular cartilage that may have occurred concurrently with that initial injury. So what is the rationale for treatment? Well, again, the number one rationale for treatment is the unstable knee. No patient wants to have a knee that cannot support them during any activity, particularly in sporting activities, but even simple day-to-day life. As I demonstrated in that video of the pivot shift, you can see where that would be very unnerving, to have a knee that simply you twist a little bit and the knee will shift like that and feel like it doesn't support your weight. However, there is potential for secondary injury, which is important in terms of knee health. So concurrent injuries include additional injuries such as the medial collateral ligament from a blow to the side of the knee, or cartilage damage that can occur either to the surface cartilage or the meniscus. But what can happen in ACL deficient knees, because of that looseness, you can tell that there's a fairly dramatic change in the alignment of the knee. And when that occurs with more force, for instance, in a patient who's running or twisting, there may be damage that occurs to the meniscus at that time. So in ACL deficient knees, in high-level athletes, some reports are as high as 98% of patients will go on to tear their meniscus. So that's why we tend to be more aggressive treating particularly athletic patients. As you start to damage meniscus and articular cartilage, that's when patients get into trouble with what patients are always worried about, which is arthritis of the knee. Arthritis in this setting meaning degeneration or loss of the surface cartilage, so that the cartilage doesn't move smoothly and becomes painful, and the knee tends to hurt with most activities. So what are the treatments? Non-operative and operative are the two choices that we have. This is a picture here of an ACL deficient knee, of the left knee, and you can see the torn ACL in the middle of that notch. So non-operative treatment for isolated ACL tears may be successful in a small subgroup of patients. Studies have shown that some patients are able to cope with ACL deficient knees. Oftentimes there are advantages when patients have only partial tears and they don't have instability episodes, but some patients who have complete tears are able to participate if their knee is not grossly unstable, and more importantly, if they don't experience instability episodes. Some of these patients are all called copers, but it's difficult to select out who these patients might be. Other patients who may be good candidates for non-operative treatment are patients who have low-demand jobs or live sedentary lifestyles. However, for anybody who is more aggressive athletically or wants to get back to routine activities without worrying about their knee, or more importantly, patients simply who have unstable knees or may have other injuries, will require surgical treatment. So surgical treatment is directed at arthroscopically replacing, not repairing, the ACL. We call this an ACL reconstruction. We're rebuilding the ACL. Repairs have not been shown to work well because of the nature of the injury causing damage to the ligament over its course. So once that ligament is damaged, it cannot be stretched back out to span the distance between the femur and the tibia successfully. Some studies show that there's a slight benefit, but generally speaking, it's not an accepted treatment. So for operative treatment for the ACL, when we reconstruct the ligament, we use a substitute tissue. And biologic tissue is the best for this new graft. The research has tried using ligament substitutions, such as ACL substitutions, has tended to not work well. So again, ligaments are usually reconstructed with tendon grafts, and we'll talk about those in a moment. Some scientists back in the 80s and 90s tried using synthetic grafts, such as Gore-Tex or Dacron. But just like any other material, your jeans or the shoes on your feet, these structures will wear out over time. And the debris that occurs from that wearing out tends to cause more destruction to the knee than any benefit that one would have from the ACL reconstruction. So in terms of graft choices, there's two sources of graft. One is what's called an autograft, like an autobiography. This is something from yourself. These tissues have the advantage of being stronger, no disease transmission concerns, and there is no immunologic response that you might be subjected to. The problem is you have to take that ligament out of your knee. That new ligament has to come from someplace. And so there's what we call graft site morbidity, or pain from where that graft is harvested. The most common graft sources for autograft are the patellar tendon, which, as we mentioned, is the strip of tissue below your kneecap, or the hamstring tendons, which are the tendons on the back of your thigh that extend all the way down to the bottom part of your knee on the inside. Now, allograft tissue has the advantage that there's no graft site morbidity. You don't have to worry about sacrificing any of your normal tissue to replace the ACL. But the disadvantage is that there are always concerns about immunologic response, in other words, your immune system fighting off that ACL, or the possibility of infectious complications like HIV or hepatitis. Luckily, we have not had any complications such as this for many, many years, probably back into the 1980s, and some bacterial infections were reported early in 2000, but realistically speaking, our processes now with bone banks of harvesting and processing these grafts is excellent. The most common allografts that we use are patella tendon allografts, Achilles tendon allografts, and then a tibialis tendon allograft, which is a tendon in the front of your ankle. So how do we do this? Well, the graft is inserted arthroscopically into the knee, and it's done by creating tunnels in the bone. So again, I'll come to my model, and you can see from this diagram what we're going to do is we're going to try and recreate where this graft is. I'm not sure how well you can see this, but the ACL is sitting here right in the front of the knee. So in order to create a new ACL, we are going to drill a pin from the front of the tibia here. It will come out inside the knee joint here. We'll make another tunnel inside the femur here, and that pin will then pass out through the knee joint. So that's what that diagram is showing there on the right. You can see that we've created tunnels both in the femur and the tibia. The reason for the tunnels is that allows for a better ultimate growth of the new tendon/ligament into that bone, which ultimately, when it heals, will then function more normally. Once we get the graft into those tunnels, that new graft is held in place with fixation devices such as buttons or screws or pins. You can see on this photograph or diagram here, looking from the front of the knee, I've elected to show an image that shows a button used on the femur side that is then looped around the graft. And similarly, on the tibial side, we'll then use a screw or a button to fix the graft on the lower end. Fixing the graft in both places allows that graft to then heal into those tunnels and ultimately become biologically incorporated or healed into the knee and function as a new ACL. So this is an image of a left knee. We're looking from the front of the knee arthroscopically. I'm going to show a video of us placing this graft into position. You see these green strings or sutures that are traversing the joint. They are attached on the lower end to the upper part of the new graft that we're going to pull into place, and it's going to come from the lower left side of your screen to the upper right side. In the distance in the far right side, you see a little hole. That's the tunnel on the femoral side, on the femur side of the joint. And the tibial side you'll see on the lower left. So as we pull this, we're going to seat this graft into that tunnel. So here you see my assistant's pulling on the strings. There's two strings. One is to pull the graft into place. The other is to flip this button so it seats over the end of the femur. So as you see, there's the button going up, and now you see the new graft going into position. And you can see as it fills that tunnel very nicely. In just a moment, my assistant will tighten that by just flipping a little bit. It'll make the picture bounce a little bit. And then you'll see me pull down as I pull the graft back in, seating it beautifully in place. And then what you won't see on this image now is that I will fix the lower part of the graft with a screw, holding it in place so that the ACL will then heal. So rehabilitation, this is actually the hardest part of the surgery. This is the part that the patient has to take care of. I call it a 6-6-6 recovery. This means 6 days, 6 weeks, and 6 months. 6 days is just the immediate postoperative period. This is a miserable experience, unfortunately. Despite being an arthroscopic procedure, this is a painful operation. So what this means is you should make plans after having an ACL reconstruction to be at home for a week, taking your pain medicine, staying off your feet, icing your knee. You can do some gentle range of motion during this first 6 days, but mostly it's just to stay home and take it easy. The next 6 weeks is called early rehabilitation. What this means is at the end of the first 6 days, you have still a painful and swollen knee, but your pain is now tolerable. We're going to take that knee, have a physical therapist work with you to regain your full range of motion, get off the crutches, be able to weight bear, have very little pain. So by the end of this 6 weeks, your knee will function relatively normal in day-to-day activities, walking, driving, things like that. Then comes the final 6 months, or the late rehabilitation. This is where patients slowly regain their confidence and their strength, and the graft regains its strength to be able to accommodate progressively more aggressive sports. So running is at about 4 months, lateral motion sports at about 6 months, and return to full activities after that 6 months, or a total of 8 months after you add the 6 plus 6 plus 6, is when patients are allowed to return to their usual activity. Now, outcomes from both autograft and allograft reconstructions is greater than 90%. There are a few outlier studies that show that allografts may have a slightly higher failure rate, but generally speaking, the accepted rate is in the low to mid 90s in terms of excellent and good outcomes for both ACL reconstructive techniques. There are complications that can occur with either graft, and simple surgical complications such as infection can always happen. But unique to ACL reconstructions are, of course, the risk of a failure of the reconstruction. This is generally not a failure of the procedure. It's that the graft is never as strong as we'd like it to be in terms of performing as well as a native knee. And when patients return to a very high level of athletic activity, there's always that risk of re-injury. Stiffness of the knee is always a risk with any joint surgery, and in ACL, it's not unique. ACL surgeries can cause stiffness, which is why rehabilitation with a good physical therapist is essential for a good outcome. And finally, anterior knee pain, which is a pain on the front of the knee, not related to the surgical incisions or the procedure itself, but rather to the slight change in the biomechanics. In other words, we can make the knee very, very good, but we can't make it the way that it was before the injury. So there's always the risk that there will be a slight imbalance, and this can cause pain in the front of the knee. This happens in about 10% of patients, usually resolving after 1 or 2 years, but some patients may have residual pain after that. So what are the special circumstances I spoke about before? Well, again, revision ACL tears requiring reconstruction are always a bit more challenging. At times they can be more easily performed because the tunnels are already in place. So sometimes it's simple as pulling the old graft out and putting a new one in. That can be easy. But if there were some technical difficulties that occurred in the previous surgery, such as the tunnel not being placed in exactly the right spot, there is risk for being a bit more challenging trying to get graft position in the right spot. The other challenge is the pediatric patient. Pediatric patients, again, have growth plates, and these growth plates still afford the knee growth despite having the ACL injury. So if you do anything that violates that growth plate, there's always a risk for growth disturbance. It is not common with the techniques that we're using now, but in the much younger patients, that certainly is something to consider. Now finally, a word about prevention. I always tell people prevention in ACL surgery is a little bit like sitting on the Golden Gate Bridge and watching the traffic and waiting for the traffic accident to occur to be able to study what happens to the passengers in their cars. We have a difficult time recreating in a lab what happens biomechanically or hormonally in a knee joint so that we can study it over and over and over again the way car companies can do in a laboratory. Now, studies have looked at hormonal, anatomical, and environmental risk factors for ACL ACL injuries and have shown that no evidence is available to support the use of hormonal substitution or change in hormone therapies, prophylactically operating, for instance, on narrow notches to decrease the risk of ACL injury. And again, shoe wear modification is difficult to find that proper balance between traction and lack of traction. So most of the prevention studies look at biomechanical changes. This is where we have probably the best chance of changing that risk of ACL injury. Now, in order for this to be effective, athletes must participate in prevention training for at least 6 weeks prior to their activity, and it's generally recommended that they do this twice a week, if not more. Balance training is essential. Balance training is usually done on a balance board, where a board is placed on a round ball so that one has to learn how to manage their balance or they fall off of this balance board. High-intensity jumping is called plyometrics. This was designed by a Russian scientist back in the 80s, where Soviet athletes were instructed to jump off high surfaces several feet in the air and then instantly jump back up again in a very short response time. This training trains the muscles in what's called an eccentric contraction to perform well, and this usually will bail people out in circumstances that otherwise might injure the ACL. Strengthening and stretching programs are a very important part of all athletic programs and are part, but not solely, responsible for success in prevention of ACL injuries. And then what about biomechanical analysis? Well, this is important in terms of studying how people run, how people ski, and how they fall during these activities. There's a number of studies that have looked at how people injure themselves during activity. For instance, running and landing on a straight leg tends to have a higher incidence of ACL injuries than when you land on a bent knee. When you're skiing, as you fall back, if one of your inside ski turns uphill internally or inward rotating your tibia, this creates ACL injuries. So learning how to fall and change these behaviors before they occur may help you in these incidences. So for instance, one study looked at ways of changing basketball players' strategies in a game. So they use an accelerated rounded turn through a corner to get to an open part of a court instead of doing a hard pivot and cut to get to a different part of the court. Landing on a bent knee as opposed to landing on a straight knee after a layup or after a jump shot will be, again, a more effective strategy to decrease ACL injuries. And simply trying in a soccer game, for instance, to decelerate over 3 steps as opposed to 1 step may help to decrease ACL injuries. Again, many of these injuries, unfortunately, are going to occur simply because they are accidents that do occur in day-to-day life in these sporting activities. So in summary, ACL injuries are common sports-related injuries. 100 to 150,000 occur every year. Most ACLs occur without contact. These injuries occur simply from cutting-type sports. Surgery is generally recommended for patients who want to return to an active and athletically demanding lifestyle. And finally, prevention, though not perfectly figured out at this point, is something that we would love to work towards improving, and I think more of these studies are going to come forward over the upcoming years to give us better strategies to prevent these ACL injuries from occurring in the first place. So I want to thank you very much for joining me today. On behalf of Sutter Health Community and all those folks who have helped me put together this webinar, I want to thank you. A reminder to complete our webinar survey, which you'll see in the middle of your webinar console. And now we'll move to the question and answer period. And I think our producers have a few questions that they're going to go ahead and put up for us at this time. Okay, so here is the first question. What is the best way to bring back a soccer player after a 9-month rehabilitation from ACL replacement or reconstruction? And the answer is, based on what we talked about before, this is a staged rehabilitation. And the reason it's 8 or 9 months is we want to make sure that patients don't try and accelerate that too fast. In other words, if you're going to go try and lift weights and your goal was to lift 100 pounds, you wouldn't start with 100 pounds and ask your friend to lift it off the bar. You would start with 5 and work till 10, 10 to 15, 15 to 20, and only when you're comfortable with the stage before will you move to the next phase of the recovery. So generally speaking, when you are doing these sorts of activities, you start off with stationary bicycles so there's no impact. You may do a treadmill or an elliptical trainer. As the leg starts to build up its strength, at about 4 months when the graft is a bit stronger, one can start running, usually on a treadmill, then on a track, and then running out on natural surfaces. At about 5 to 6 months, patients can start general cutting. The reason for the cutting is to try and increase some of the lateral strength that the ACL may be experiencing, or the lateral strengthen the graft to those lateral stresses. I generally recommend that my patients do not get back into a high level of activities, particularly game situations where patients have a much more difficult time restraining their activity and slowing themselves down to prevent knee injuries. So at 8 months, they generally are ready to get back to sports. Okay, next question. I had ACL surgery on December 18th of 2011. I had serious pain in my knee up until 5 weeks ago, and I had surgery again. They said I had a lot of scar tissue. Now the pain is not as bad, but my shin is numb. Is there any way of getting rid of this numbness? Well, the numbness from the surgery is not likely related to the ACL surgery per se. Let me qualify that a little bit. When we do the ACL reconstructive surgery, there's a small incision we have to make at the bottom of the knee joint at the top of the tibia. Remember that slide that I showed where we drilled the pin across the knee joint to allow us to place the tunnels in the joint. Where we make that incision, there's a nerve, which is a substantial nerve that creates sensation towards the outside part of your leg just below the knee. This nerve can be cut during this incision because it is a very small nerve that can't be easily visualized. Now, the numbness that you may have experienced just from 5 weeks ago was probably there if it was related to that ACL surgery back in 2011. The surgery that you had to clean the scar tissue out of your knee, my guess is, was done arthroscopically. And if it was done arthroscopically, the little holes in your knee are not likely to cause any major nerve damage. Now, to get to your question, is there any way of getting rid of this numbness? The answer is, if you had it since 2011, it is likely going to be permanent, unfortunately. It's usually just a sense of numbness around the area, will not cause any functional loss to the leg. On the other hand, if you've had this numbness ever since the scar tissue operation, which was done 5 weeks ago, there's still potential for that to get better, although the longer you are away from the surgery, the less likely it is to improve. Okay, next question. I had a total ACL tear and reconstruction using my own parts, assuming patella tendon or hamstring as we talked about, which healed great. Since then, I've had a re-injury, arthroscopic surgery to remove cobblestone pieces, and I'm still suffering from pain to the point of not being able to move my left knee in certain positions. I'm told it is not related to my ACL. Could this still be a factor, though? My pain comes from movement of my knee to the side, but I don't have any looseness. So this is still the problem with ACL surgery. When we take an ACL deficient knee like you saw on those videos, you know that knee is very loose, and that's just a recipe for disaster in a patient who wants to return to sports. When we do ACL reconstructions, we're trying to restore the knee to as normal a condition as we possibly can. So we have done research on ACL reconstructive surgeries to try and reproduce exactly where the ACL is placed. There are some centers now that are working on what's called the double bundle technique. The double bundle technique means that the surgeon is trying to recreate the two branches of the ACL that have been defined. The problem is that can be technically difficult and can also create bigger problems down the line. Now, most ACL surgeries, as we talked about before, have 90 to 95% successes. But there is, because we cannot make this a perfect knee, the risk that the knee will still have issues moving forward. This is why ACL injuries are not favorable injuries. And so what you probably have is a little bit of early degeneration in your knee despite having a successful ACL. So when the surgeon says that your pain and your sense of discomfort when you move to the side is not due to your ACL, well, your ACL is probably successfully reconstructed. But now you're showing early signs of degeneration of the knee. Not to the point of having full-blown arthritis, but this is part of what's possibly part of your problem. We have another question. I recently tore my ACL, and they are giving me the option for surgery. If I'm not much of an athletic person, mid-40s age, should I just let it heal naturally or do surgery? Well, this is a very important question. There have been numerous studies showing that patients can successfully proceed without having surgery. There was a surgeon actually at Kaiser in San Diego named Dale Daniels who looked at patients who had ACL tears and did not offer them immediate surgery unless they had additional injuries such as cartilage damage. And he found that a large portion, approximately 1/3 of patients or more, could progress without having surgery as long as they limited their activities. Now the problem is that one never knows when they're going to have that one twist when they tear their cartilage in their knee, and that additional injury creates more problems for the knee moving forward. And so the idea is that if you really think you're willing to change your activities to linear activities such as cycling, swimming, minimize any risk of twisting, and if you don't experience instability episodes, that sense of a pivot shift of your knee, even with simple activities such as turning the corner when your name is called or turning to get something off the counter in the kitchen. If your knee has that level of instability, you should definitely have it fixed. Now, the problem with medicine is not an exact science. I've seen people with the loosest knees in the world have almost no arthritis. And I've seen people who have had an ACL for a week and simply go to pick something up and tear their meniscus. How those two presentations are different, I don't know. These are the things that we can't control. So when we have patients who tend to be more active, we lean more towards surgery. I think if you're in your mid-40s and you're willing to accept a more sedentary and linear active lifestyle, it may be reasonable to try and rehabilitate your knee as much as you possibly can, and then be honest with yourself about how loose your knee actually feels when you're active, and then make the decision as you move forward. Do we have any other questions? So if you have already had a torn and repaired meniscus, are you more or less susceptible to having an ACL tear? Thanks, and thank you. The answer to that is probably not, but I'll qualify that statement. Generally speaking, the ACL protects meniscus, and it does so by stabilizing the joint and making the joint run properly. No different than the tires on your car need to be aligned to make sure your tires don't wear out. Now, the problem with your scenario is that you had the meniscus fixed. That does meniscus repaired, which means that you had a tear and it was placed back. It may simply have been partially removed. That may allow for some instability to the knee, but it won't subject the ACL to enough force necessarily that it would cause any increased risk of an ACL tear. Now, the reason I said I'll qualify it is that a lot of patients will tear their meniscus when they've got some ACL looseness. So if you've had a previous ACL tear that either went undiagnosed or maybe was a partial tear, that may be what caused your meniscus tear. That is not always the case. Many people tear their meniscus without ever having a problem with their ACL. So that would be the only reason that your ACL would be more susceptible, is if you had a remote ACL injury you didn't know you had, and that may have caused that meniscus tear, as we talked about earlier in the program. And another question. Does tendonitis make an athlete more prone to an ACL tear? The answer to that is no, it does not. Tendonitis simply is an inflammation of a tendon that occurs with overactivity. And so when you have tendonitis, you may change your activity level and will actually probably make you less active. Now, that probably puts you at less risk actually for developing an ACL tear, but the two are not in any way directly related. Now we'll look for the next question. I hear about people talking about ACL and PCL a lot, but what is exactly the difference between the two? This is an excellent question because you'd think, well, if the ACL is bad, how come the PCL is not so bad? There's a number of reasons for that. The first reason is that the ACL is responsible for prohibiting the translation of the tibia forward underneath the femur. As you bend your knee and fire your quadriceps, that amplifies that distortion of the knee joint. The PCL does the exact opposite activity. What it does is it minimizes the translation of the tibia backwards underneath the femur. And so what happens is that when the quadriceps contracts, that actually pulls the tibia forward and pulls the tibia back into proper position. So this is actually one ligament in which keeping your quadriceps strong actually will definitely change the longevity of your knee, whereas in an ACL it may not change the instability pattern whatsoever. Now the other thing is that ACLs, because of this amplified translation of the tibia forward that can occur and the increased incidence of meniscus tears, one is more prone to developing arthritis after an ACL tear that is left untreated, that goes on to tear the meniscus and causes more problems down the line. Whereas with a PCL tear, this does not happen that frequently. We just don't see that many injuries to the meniscus after PCL. The other thing is that PCL reconstructions are not quite as successful as ACL reconstructions, so we tend to be a little more conservative unless patients have dramatic symptoms or unless the ACL and the PCL are torn at the same time, where we do multiple ligament reconstructions. And that can also be seen with lateral collateral ligament and PCL ligament tears as well. Next question. So how, you mentioned before prevention. How can I strengthen muscles around the knee with physical rehabilitation to prevent ACLs? Well, as we talked about before, leg strengthening is very important. Just starting off with simple training, both in terms of cardio training and strength training, will help your ACL. The reason is that when you're skiing or you're playing soccer, as you fatigue, your form tends to degenerate. So simple strengthening is going to help that type of fatigue that you're going to get in sporting activities. So when you start to get into trouble with your knee, you're able to bail yourself out in a ski fall, for instance. Now, balance training gives you what's called proprioception sense. That means as you feel your body starting to move out of its comfort zone, in proprioceptive training, when you stand on that balance board, you'll be more prone to be able to recover from that sort of abnormal position that your body might find itself in. And then finally is plyometric training. Now, plyometric training has been translated into American culture now, simple jumping sports, so step aerobics type thing. But it was originally designed to be more of what's called an explosive eccentric contraction with Russian athletes. So the idea is that you jump from, say, a box, maybe 1.5 feet high, 2 feet high, and as you land, you absorb the shock quickly and then jump back up again. That quick explosive rehabilitation will make your quadriceps stronger, but it also trains you to be reflexive and responsive. Now, much of that happens on an involuntary level. It can't be controlled. But if you train yourself, you can have your muscles work better and perform better during your activities in hopes that that will decrease the risk of injury. So those are the things you can do to strengthen your muscles. So leg presses are good for strengthening. Do not do knee extension exercises. They tend to be hard on people's kneecaps. It's a bad training form, in my opinion. I think leg presses work better. Elliptical trainer tends to be the best cardio workout, although stationary bicycle is excellent. Hamstring curls are also excellent to work on your hamstrings, keep the whole leg balanced. And then in terms of activities, there are programs. You can search these out through the web or maybe through your local physical therapist about certain training programs, and particularly with things such as skiing, ways that you can bail out of a ski fall, for instance, maybe to minimize risk to your joints. Okay, next question. Occasionally I hear a pop in my knee without pain. Should I be concerned? The answer is most of these pops are not to be anything to be worried about. No different than when your kid cracks his knuckle, anything like that. Now, if it's painful, it usually means that there's something problematic. But pops are simply two pieces of tissue rubbing over each other, and the static from those creating a noise is not to be concerned about. Next question. Is there a disadvantage to have ACL replacement done 2 or more years later than after the ACL was torn? The answer to that is that the longer you are out from your ACL injury, the more at risk you are for developing a meniscus tear. I've reconstructed ACLs on patients who have had ACL instability for 20 years. And if patients have simply not gotten around to it, or the knee felt unstable, but there wasn't that much of a problem, or they restricted their activities. I have patients who have not had ACL reconstructions because they were single, and then when they had kids and they wanted to coach with their kids, their soccer team, their knee felt more unstable, and they felt that it was necessary to reconstruct it. But again, the risk is not so much of the instability other than the fact that it feels unstable, but the risk is to the subsequent injuries that can occur, particularly to the meniscus and the articular cartilage leading to degenerative changes. Next question. My elderly mother has weakened leg muscles, and I'm concerned that she may have injured her knees during normal daily activities. Can she get ACL injuries, or should be more concerned about broken bones? Well, obviously, weak leg muscles are going to put your mother at risk for falls, which, of course, may put your mother at risk for fractured hips, which is what we worry about mostly in elderly females. Now, the likelihood of your mother having an ACL injury is very small, and in her day-to-day activities, as we talked about having patients with sedentary lifestyles, we don't really worry much about ACL injuries. Again, your question about broken bones, it's not likely that her legs are weak because of broken bones, but the weakened leg muscles can lead to that. So it might be reasonable to have her get into some physical therapy and work on some strengthening of those weak legs. Next question. What are the different ways to diagnose a torn ACL? Is an MRI the only way? The answer to that is no. The best way actually to diagnose an ACL is not an MRI. In my opinion, the best way to diagnose an ACL is through clinical examination, as I demonstrated on that pivot shift. I think if a patient demonstrates clinical instability, that demonstrates that their knee is going to be unstable when they stand on it. The MRI is simply a static picture of the ACL in its torn phase. And I've seen patients who have had ACLs read on an MRI, and they have been read as torn, but patients clinically have stable knees and successfully go on to have non-operative treatment. Now, my personal feeling is that the two are really complementary to one another. So the MRI and the physical examination are clearly the two most important parts of that diagnostic triad. Next question. What are the options for a torn meniscus? Well, there's basically three. Depending on how bad the tear is and how clinically symptomatic or how bad the patient feels with it, you could, in theory, leave it in place. And I've seen this before. Generally speaking, the meniscus is not a vascular structure. It has very little blood supply. So like your hair or your fingernails, if you cut too much off, you can't stitch it back together and hope that it will heal. So the meniscus rarely successfully heals. So in most cases, we generally trim the meniscus out. Now, when the meniscus is a much larger tear or has potential for healing, we will stitch it back in place because we want to make sure we maintain as much of that meniscal structure as we can. So in larger tears, let's say 80% of the meniscus is torn, we may try to repair it. Whereas in smaller tears, 10 to 20% of the meniscus, we'll trim that out, leaving a healthy 90% of the meniscus. Now, in an ACL deficient knee where there's a higher susceptibility for meniscus damage, we tend to be very aggressive fixing the ACL and then fixing the meniscus. Okay, so in a torn meniscus that's in conjunction with an ACL, that's when we'll tend to be as aggressive as we can. I have pain in my knees when squatting. What causes this and what can I do for it? Well, generally, that's a completely different situation than ACL. That's what we call anterior knee pain syndrome. Now, that is part of those problems that we talked about as a possible side effect or complication from ACL surgery. But what that's due to is as you flex your knee, as we mentioned, the patellar tendon and the quadriceps tendon, as you bend your knee, I'll show you on this model here, as you bend your knee, you tend to put more stress on the kneecap as the quadriceps and patellar tendon structure goes over a corner of your knee. As you continue that flexion, you'll see that that stress becomes greater and greater as that mechanism gets drawn over the corner of the knee. So the deeper the squat, the more stressful the stresses, the more pressure that stress creates on the front of the knee, and that's what will cause more pain with those types of activities. So if you want to do squatting type activities, I would try to minimize the episodes that you do it. In other words, Don't do it as a part of a routine exercise program. Avoid stairs and hills because the repetitive nature of that is what causes your discomfort. I think we have one other question that was written in here. The one about born varus. So I was born varus. What varus means is bow-legged. I was born varus and have advanced osteoarthritis. Are there any new treatments besides what is called viscosupplementation injections or cortisone injections? I have no joint space left on the right, and the left has been without the ACL for about 3 years. So the answer to that question is it depends on the degree of discomfort the patient's experiencing. I've tried to break it down into 3 treatment arms: physical treatment, medical treatment, and surgical treatment. So physical treatment means simply avoiding the activities that tend to aggravate your knee. So if you're still playing basketball, you want to try and decrease those activities. But if simple walking is bothering it, well, then you have to start thinking about other ways of managing your pain. Braces can sometimes be helpful. Ice temporarily will give you some discomfort relief. Medical treatment is the second arm of that treatment triad. That basically is pills and shots. Pills generally are anti-inflammatories like Advil or ibuprofen. Shots are cortisone. Viscosupplementation is another type of medication which is injected into the knee in hopes of lubricating the knee just a bit. Surgical treatment for an arthritic knee generally is going to be a knee replacement. It is a very successful procedure that we do a lot of and have very happy patients from these. What's very interesting about total knee replacements is of all the ligaments in the knee that when we do a knee replacement that we sacrifice, the ACL is the only one we generally take out. Sometimes in certain designs of knees we'll take out the posterior cruciate ligament as well. But isn't it funny that the one ligament that we try to save so much in a knee that has no arthritis is the one ligament that we're prone to remove when we do a total knee replacement. I think we have another question. I have pain in my knees when standing. Oh, I'm sorry. I had a right knee injury at age 13. My right leg is short 2 inches on the femur bone. What are my options? Well, it kind of depends on your age. It depends on your activity. It depends on how much it's bothering you. There are certain techniques that we have now that you can shorten your other leg 2 inches. So if you're very tall, that would not be an inappropriate thing to do. If, on the other hand, you don't want to sacrifice 2 inches from your other leg, you can actually grow bone on the short limb. So what happened is that when you were 13, you damaged the growth plate. I'm not sure if it was in conjunction with an ACL injury, but again, these are the concerns we have on younger patients. But if your limb is 2 inches short, you can actually put pins in the bone and attach them to a bar, cut the bone, and actually trick the bone into growing 2 inches longer. Again, that's a lengthy procedure. It takes about 3 to 4 months of having this frame outside of your leg. But if it's a significant disability, it's a very reasonable thing to entertain, and I'd be happy to discuss this more with you in the future. Well, thank you again, and on behalf of the Sutter community, I want to thank you for joining us today. I'd like to thank the producers of this program. And again, if you would be so kind as to fill out the survey on the webinar, I believe it's on the contact page, that would be wonderful. Hope you have a nice evening, and hope you save your ACLs. Good night.